All right, well, I think we'll go ahead and get started. People can join us as we go, but we're glad to see everyone here with us today. We're here today to hear the fifth seminar in our Behavioral Health and Tobacco Dependence Treatment Seminar Series. We're excited to be here. We get to hear from Bassema Abu Farsakh today. She will be presenting Documenting Tobacco Treatment Best Practices for Success. I know I've met most of you, but just to introduce myself again, I'm Emily Koyagi, and I'm the Program Manager for UK's Behavioral Health Wellness Environments for Living and Learning, which we lovingly call Be Well. Before I get started, I want to mention a few things. We are recording this presentation, and so after it's done, probably today or tomorrow, we'll have it up on our website. So if you hear things today that you think of a colleague that might be interested in hearing it, we'll have that link that you can share with them, and we'll also share the slides. So that should be up in the next couple of days, and I'll follow up with you all about that. During our time today, you can feel free to use the chat or virtually raise your hand and unmute yourself if you have a question or comment. We always want this to be a comfortable, relaxed environment where you can share your thoughts and questions, so please feel free to do so. We'll have the presentation first, and then we'll have time for Q&A and discussion. So if you have questions during that portion, we'd love to hear from you. We like to always say, while you're listening today, to think about three things. One is your main takeaway. The second is a frustrating or challenging thing that you've heard during the presentation or that you've dealt with before that maybe you want to share and get some thoughts on, or something positive, a positive experience that you've had when dealing with this topic and something you might like to share with others. So we'll go ahead and get started. And again, we're so glad you all are with us today, and I will hand it over to Bassema.
Hi, everyone, and thank you so much for joining us today. I am Bassema, and I'm going to talk today about documenting tobacco treatment best practices for success. Our objective at the end of lecture today are to describe ways to maintain accurate records that are appropriate to the setting in which services are provided. Then we will be able to discuss diagnostic codings for tobacco use, dependence, and exposure. The third outcome today is to be able to describe a protocol for tracking client follow-up and progress. And finally, to be able to discuss standardized method of measuring recognized outcome of tobacco dependence treatment for individuals and programs. For our first learning outcome, maintaining accurate record, as all of you know, documentation is very essential in healthcare field. Documenting and record keeping are a core component of best practices for healthcare. And it is important to be able to use or utilize codes for tobacco dependence treatment within our record and record system in order to accurately document and obtain reimbursement for this treatment. And it's incumbent these days upon the clinician to ensure that appropriate billing guidelines are followed and recognized that reimbursement of these codes may be varied by payer. So again, here it's important for all of us to be aware about codification system available in our institution in order to be paid for that service. Now, all of you know that documentation is important and our record should be accurate, written in a timely manner, and with a high quality. And what we are going to document actually is what type of services we provide, and along with the codes, we are going to document patient status prior, during, and after the visit. We are going to use paper and electronic formats to document our finding, and we actually use this documentation for clinical care and improve patients' clinical outcomes. There are 5 system strategies that are available to ensure that agencies implement tobacco treatment protocols appropriately. The first strategy is to have identification system for current and former tobacco users in every clinic. The second strategy is to provide adequate training and resources for staff to provide services. The third strategy is to dedicate and assign staff to provide tobacco dependence treatment. And the fourth strategy is to promote hospital policies that support tobacco dependence treatment. And finally, to ensure that the health insurance packages cover tobacco dependence treatment services. So that's all for our first objective. For our second outcome is appropriate coding. As all of you know, in different settings, we have different codification systems. So it's very essential for us to be aware about the codification system used in our agency and what's often tied with billing services. And it's important to be aware about that in order to be well paid for that service. The codification system in the United States usually belong under one of these three or more. The first one is the Diagnostic and Statistical Manual of Mental Disorder, the DSM-5. The second one is the International Statistical Classification Disease and Related Health Problem, or what we call ICD-10. And the third one is Current Procedural Terminology, or CPT. The ICD-10, which is approved by the American Psychiatric Association, it contains the standardized criteria and definition of mental disorder. As you see here, there are 4 types of codes that we can use based on the DSM-5 criteria. The first one is tobacco use disorder mild. The second one is tobacco use disorder moderate or severe. Third one, tobacco withdrawal. And the fourth one is tobacco-induced disorder. Now, the second one is the ICD-10, and the ICD-10 is code are developed and are maintained by CDC National Center for Health Statistics under authorization by the World Health Organization. The ICD-10 codes contain codes for disease, signs and symptoms, abnormal findings, complaints, social circumstances, and external causes of injury or disease. The ICD-10 is more often used for billing services rather than the DSM-5 codes. Based on the ICD-10 codes, healthcare providers need to be aware where to put patient under which category to ensure that the patient is that we assign appropriate code based on the appropriate patient condition. So providers need to be aware about patient's tobacco use, or patient is under tobacco dependence, or whether they are exposed to tobacco, for example, they are second tobacco smoker or have a past history of tobacco use. There are many charts that help clinicians to be aware or to decide which codes should be selected based on which patient condition. Let's say that we have a male patient who uses tobacco, who smokes cigarettes, and we'll follow this chart based on that. So the first question would be, does this patient use tobacco or smoke? We'll say yes. Then, is this patient pregnant? No, because he's a male. Does this patient have nicotine dependence? So we're going to assess patient nicotine dependence, and we'll find that he is nicotine dependent. Based on that finding, we will see what kind of nicotine does the patient use. Is he using cigarettes, chewing tobacco, other cigarettes, or it's not clear. Based on that, the providers need to put or assign the appropriate codings. Now there are many codings for the ICD-10, and I left all of these codings at the end of this presentation for your reference. Here are a few tips for providers where their agencies use the ICD-10 or the DSM-5 codes for documenting purposes. Those providers should be specific about typing or documenting the type of tobacco product that they use, the frequency of using these products, and any pertinent modifying factor and any complications to support the ICD-10 codification system. So for example, instead of saying only current tobacco users, it's better to say current smokes a few cigarettes a week when out with the friends, or smoke one pack cigarettes a day with nicotine-induced COPD. And for those who are non-smoker, it's better to say non-smoker or no exposure, or patients denies tobacco use rather than non-tobacco users. And it's important to make sure that our electronic records came along with our paper records, and we document all of these findings appropriately. Now, recently, we have the ICD-11, which is the revised form of the ICD-10. It is almost similar to the ICD-10, but it has more categories that they will include the harmful effect of tobacco use in that category. It's not yet embedded in the systems, but it's here. It's available and it's coming soon. So I left the ICD-11 codes along with the ICD-10 codes at the end of this presentation for your reference as well. Finally, we have the CPT codes. The CPT code is the current procedural terminology, and it is a US standard for coding medical procedure. It's maintained and copyrighted by the American Medical Association. These codes are methods used to document what type of services we provide or what type of procedure to be billed for. It's similar to the ICD coding. CPT used to standardize medical communication across the board, but ICD-10 focus on the diagnosis. CPT instead identifies services provided and are used for insurance companies to determine how much provider will be paid for that service. For those who report the CPT, it is important to report in their charts what types of tobacco product they use and the frequency. Are they going to quit or willing to quit, or where are they in the stage of change? What kind of support that the providers provide for them in order to help them with a quit attempt? When they will be scheduled again to come again to see or follow up. And the most important one is to report the time that providers spend with these patients to achieve their outcomes in terms of tobacco treatment, because this code is time-based. So also the CPT-10 codes is included at the end of the presentation for your reference. For our third outcome, tracking progress. Now, setting up a protocol for your organization should be for other similar protocols used in assessing clinical progress. Tracking progress start by 5 A's again. The first one is for asking patient every visit about their tobacco use. We need to track progress, train staff on tracking progress and documenting it to ensure that everyone in that facility is following the protocol. And we need other trained people to review client records regularly to examine adherence to that protocol. Now, why it's important to keep tracking protocol or tracking patient progress? Because tracking protocol is reflected patient progress. As you see here in this table, it's an outcome of a meta-analysis of 46 study. The finding of this analysis shows that those patients who are exposed to 8 or more sessions of counseling has more chance to report smoking abstinence than those who received 1 or no smoking session, which means like those patients who tracked for more time reported higher or better outcome than those patients who received nothing or only 1 session without follow-up. And every time we have a patient who's visiting and he's recently quit or trying to quit, we will ask them about the benefits of quitting, including the health benefits that they experience. For example, we can ask them, what are you noticing? Then we need to ask them about success, the patient, about their success. For example, how they manage their withdrawal symptoms by asking them what has been working well for you. The third item to ask the patient about the problems that they encounter and anticipated the threat to maintain abstinence. For example, did they report depression, weight gain, increased alcohol, or being surrounded with other smokers, all of these kind of challenges. So we'll ask the patient what has been challenging for you. And finally, if patients receive medication, we will ask them to tell us how the medication is working for you. Now, tracking progress, it can, providers can tell that there is a progress in patient condition when they report increase in importance score, or increased confidence, or increased readiness to change, or movement along with the stage of change, or change the talk about tobacco use or tobacco cessation. Here is an example about what we can report to track patients' outcome. The first one is to report patients' motivation based on the motivation interviewer scaling score. To report the patient's importance to stop smoking, how much they are confident about their ability to stop smoking, and how they are ready to stop smoking. We can also report where are they in their stage of change. Are they in pre-contemplation phase? Are they in contemplation phase, preparation, or action, or maintenance phase? And it's important in every visit to keep tracking for those to see the change in patient condition. Providers also can report the nicotine dependence findings. They can use Fagerstone score every visit to see. So the decrease in the Fagerstone scores indicated lower nicotine dependence. They also can report the number of cigarettes smoked per day for the last week or the number of cans of snuff used per day for the last week. So the change on these can indicate the progress of the patient condition in terms of tobacco use or tobacco cessation. So finally, for our fourth outcome is to describe a standardized method of measuring recognized outcome of tobacco dependence treatment. We have plenty of evidence to support that there are multiple types of effective cessation medication that can help through smoking cessation intervention. We also understand that there is a strong dose-response relation between counseling intensity and outcome. We also know that treatment or tobacco treatment can be delivered via diverse routes, such as in-person, telephone, or tailored messages. And finally, we know that tobacco treatment works in different populations. As you see here in these tables, the first one is looking for the intensity of intervention. This is a meta-analysis. Also, the finding of this study shows that out of those who received high-intensity counseling reported higher odds of smoking abstinence than those who received no counseling, which means they are more likely to stop smoking than those who receive no intense counseling. Also in this table, it shows that those individuals who receive individual counseling as a form of treatment, they reported higher abstinence rate than those who receive no services. So there are sufficient evidence to indicate that counseling is very helpful. High intensity of counseling is also important to increase abstinence. So what do we need from these? Why do we are going to do like measuring or looking for our outcomes? Because each institution is unique and we have different patient and different condition, and evaluated the program outcome among our population is really important to ensure that we applied appropriate protocol for appropriate patients. So providers need to think about questions or to evaluate their outcome. What we are measuring, typically the impact of policy and the impact of intervention. And how we are going to measure it? We collect qualitative or quantitative data. And what is the standardized method of measurement and evaluation? It depends, like how do we define tobacco use cessation? For example, are we going to look to their smoking abstinence? Are we going to look to their decrease in their carbon monoxide and their oxygen? Are they set a quit date? It depends. The evaluation began by a question. What is the effect of X on Y? So what is the effect of a 6-week educational program on quit rates? Or what is the effect of 3 counseling sessions post-quit date on abstinence? These are two of many questions that providers can think about to evaluate their outcomes. Then we need to develop our PICOT question. The PICOT questions, its P stands for patients or problem. The I stands for intervention, prognostic factors, and or exposure. The C stands for comparison, O stands for outcome, and T stands for time. Let's say an example. For P, we have a patient who use tobacco or tobacco dependent, or patient with mental illness who smoke cigarettes. The intervention is recipient of the 5 A's. The comparison, it will be between 2 groups, the people who receive treatment, which is the 5 A's, versus who receive the usual care. The fourth one is outcomes. We look to the number of people who are reporting a quit date, or a number of people who reported smoking abstinence, or many others. Finally, the time is measured over the course of 3 visits in a 6-month period. So it will be the duration of our intervention. Other types or other outcomes that healthcare provider looks for to evaluate their outcome of their programs or their protocols is tobacco use abstinence. They can look for 7 days point prevalence, which is the number of tobacco use not even above for the past 7 days, or no tobacco use. They also can look for prolonged abstinence, which means no tobacco use after initial grace period, which is about 2 weeks after quit date, or no smoking or using tobacco between 2 follow-ups. They can also look for continuous abstinence, which means no tobacco use from quit day until the time of follow-up. And finally, they can report treatment failure, which means using tobacco on 7 consecutive days, or using tobacco at least once per week over 2 consecutive weeks. In a summary, it is important that we know the appropriate codes for documenting services delivered in our respective organization. It's also documentation assists us in monitoring patient progress and conducting follow-up. Measuring the progress of patients and programs impacted the part of our work, and collection of a good data help us achieve these objectives. Thank you so much for attending our presentation today, and I'm happy to take your questions.
Bassema, would you mind just showing some of the different codings that are at the end of the
Absolutely.
PowerPoint? And I think one of the key takeaways is each of the organizations has a coding person, and it's important to work with that coding person to know what codes can be used depending on the type of client encounter. So on the one hand, healthcare providers during a particular session with a time limit, perhaps you're going to do a medication check with a patient. You typically have 15 to 20 minutes for that. In the midst of that, it is still possible to ask, while you're on the nicotine patch, how is that working for you? If you engage in that kind of conversation within 10 minutes of your encounter, you can add an additional code in terms of the procedures, the CPT procedure codes that you actually counseled on tobacco. And that comes with extra reimbursement if you add those codes. So these are examples of the ICD-10 codes that you can notice there are several that can be used specific to nicotine dependence, nicotine use, and also even nicotine withdrawal. And you have other ones where you may have specific populations at risk, where you have pregnant postpartum women, or even those who are newborns, especially with tobacco exposure. Next slide. And as Bassema had mentioned, we now have the ICD-11 that's not yet incorporated into many health medical systems, but maybe some of you have started using them. But they also have expanded codes that you can use. I think they're kind of interesting, like the PE95, assault by exposure to or harmful effects of nicotine patches. It's hard for me as a clinician to wrap my head around using that kind of code, but they do have different available codes. Next one, Bassema. And here are other ones where you have the nicotine dependence that is unspecified, nicotine intoxication, and others. Okay, next slide. And more. Next slide. Okay. And then with the CPT codes, again, in this presentation, in this PowerPoint, we are willing to share it and make it available. There are several codes that you can use during a service encounter or a procedure. And depending on the age, they're age specific. So depending on the age of the individual, and if you're providing more than just medical services, if you're doing counseling with different codes, you can add them. So if you're doing a specific tobacco counseling, you can add specific codes for how long of a duration you spent with the individual. So these are some of the codes you can use for smoking cessation counseling that are very specific to smoking cessation counseling. Next slide. So this is just more information about what the CPT codes are within the context of psychiatric therapeutic procedures. Okay. Thank you. And I'm just going to quickly share my screen to show. I'll try to enlarge it a bit. So just as an example, as we During our presentations, I recognize the question that you may be asking and often comes to us is, do we embed tobacco treatments during our regular either primary care or psychiatric care encounters? Or do we refer individuals during those encounters after doing the 5 A's, ask, advise, assess, assist, and arrange? During the arrange, do we refer them to a program? In my experience, if individuals are referred to a dedicated tobacco treatment program, they tend to benefit a bit more because that's more intensive therapy. And it includes more intensive counseling or intensive nature of the therapy. And as Bassema had shown us, if you have greater intensity, you have greater success. And many times, healthcare providers who don't have tobacco as their primary treatment, they don't have the time to do an adequate job in terms of tobacco counseling or medication management. But this is an example of a form that we typically use in that initial encounter, where we get important information about the tobacco use history. I see Christy squinting, so is that better? Sorry. Where we get pertinent information related to the tobacco use history. And this assessment, depending on how talkative a client can be done in about 15 minutes or more, depending on the person. But we get information where we conduct the pack year history to know the extent of their tobacco use. We want to understand other beverages they might be using, their age of starting, their cessation history, number 7, where we want to know their quit attempts, the longest time they've quit, their quit smoking strategies, what have they used in the past, what led to relapse in the past, what reasons do they have for quitting, stopping smoking, what is the stage of change they currently are in, their motivation for stopping, their current problems and stressors, and some of their social support for stopping smoking. We also ask their primary source of income, and this is mostly just for, again, billing purposes. And then the neat thing about this form, it helps us as providers or interveners to begin thinking of even the cessation approaches that we might take with the individual. We can use different nicotine replacement products or oral medications based on their history. We also get a brief medical history from them so that we know what medications may or may not be suitable. And we also obtain some of their information on their psychiatric diagnosis, substance use disorder history. Again, this gives us a sense of how challenging it might be for them to achieve cessation, and it helps us know how to progress in our treatment plans. And then we use these objective measures, the Fagerstrom test for nicotine dependence, which will help us know their degree of nicotine dependence. And as they progress in the treatment, we can continue monitoring their Fagerstrom to see their change and to see if our treatment is actually working. I like to also assess their PHQ-9, which is a measure of depressive symptoms. And that just helps me recognize if not only their tobacco dependence measures are changing, but if there's some other benefits to their psychiatric challenges, their mental behavioral health challenges that we can identify as they stop using tobacco or cutting down, or if it's getting worse. And then we just create a treatment plan based on our history and our conversation with the individual, and they agree with it. And, for those who are not really willing to stop at this time, we do emphasize the relevance of why it is important and why it is personally relevant to them. As an example, after doing a medical history, we may find the person has chronic obstructive pulmonary disease, COPD, and they're not ready at this point to stop using, but we help them understand. And you would think everybody actually knows this, but I'm always surprised how many people do not know the link between their smoking and their COPD or their asthma or their respiratory problems. And so it just becomes an important time to indicate the relevance to them related to why stopping tobacco use, smoking, will actually enhance, at least will reduce the deterioration of their COPD. We also talk about some of the risks. Some people may not be willing to stop themselves, but if they know that their tobacco exposure is harming somebody else, that may be the motivation they need. We talk about the rewards, and we identify some of the roadblocks, the hindrances to why they may not be thinking about stopping at that time. And then we can also refer them or give them information. So second is the follow-up forms. So after that initial encounter, which takes a bit of time to sort of gather that information, then we have almost 10-minute check-ins where we use what Bassema mentioned as the measures of progress in tobacco cessation. And one of the key measures is the 7-day point prevalence of abstinence, which means if they have not used any tobacco products in the last 7 days. So that's the question. Have you used any tobacco products in the last 7 days? If it's a yes, we go on and we still identify how many cigarettes or the products they use, their importance, confidence, and readiness. We see if there's any change. And this form I like to use as a conversation piece. So they're not just checking it off. Again, if they say, well, last week their importance was a 10, and this week it's gone down to a 7. Well, I say, oh, last week it was a 10, now it's a 7. What happened? What changed? You can use this as such a tool within the context of the motivational conversations you're having with them. And these are just some other measures. You also look at some of the withdrawal symptoms. The withdrawal symptoms are important because they help us understand if the medications and nicotine replacement is sufficient or is not. And it can help us make a decision. Do we increase it? Do we reduce it? Things like that. And one tool I recommend to tobacco treatment providers is getting an expired CO monitor. And expired CO, whenever people use cigarettes in particular or combustible forms of tobacco, it produces carbon monoxide, and that competes with the hemoglobin in your blood and reduces a person's available oxygen. So when an individual has been using a combustible tobacco product, they will breathe out CO, and it becomes an indicator of their use. When they begin ceasing their combustible tobacco use, their CO levels actually drop. And that becomes an objective marker for the person to actually see how their smoking cessation is progressing. And sometimes I just measure quality of life. Again, these are, if you have the time to do so, it just helps them see that their smoking cessation, their tobacco use cessation is impacting several dimensions of their life, not just the tobacco use itself. Then you can adjust the treatment plan as needed. So I'll stop sharing. I'd be very happy to share these forms to anybody who might be interested, see how they can be embedded into electronic medical records or used within a treatment, a tobacco treatment context. But I'll hand it back to Emily now.
Thank you. Do you all have any questions about the presentation or about the forms?
Well, I will say I'd appreciate seeing the forms if you are able to share them.
I'll send them out when I send the presentation link so I can send it to everybody.
And feel free to modify them, use them as you wish. Okay. They're not copyrighted or anything.
Thank you. Yeah, I feel like they're one of the sections on the follow-up form kind of struck me. It seems very strengths-based. It was like, how long were you able to successfully stay quit? I think that just the wording of it is very kind of strength-based, and I like that.
Absolutely. And that's a lot of our patients with mental behavioral challenges. We find that little encouragement goes a long way because they tend to experience so many setbacks. So sometimes they feel, in my experience, they say, well, I was only able to stop for like 3 days. And I'm like, that's pretty amazing. I mean, you've been smoking every single day for the last 20 years. You were able to stop for 3 days. How did you do that? And then the conversation becomes about the strengths that they had. And they identify, wow, yeah, I was able to do that, even though I did relapse, but I was able to stop. And then we can talk about, well, maybe the treatment plan needs to be tweaked. At least it worked for 3 days and then it didn't. So let's see if we can get it to work a little longer.
Do we have any other questions? We'd love to hear from you. Okay, we have a quiet group. We might have to get our Professor Acoli to use his techniques, his classroom techniques.
Well, we just ended classes, so I'm getting the sense everyone wants an early summer break and to enjoy the nice weather outside.
Yes.
Yeah. But, you know, yes, if anybody, I do have a question because we presented a lot about coding and people tend to fall asleep on me. So that's why I got Bassema to do the presentation when we present coding. But how do you see some of these coding aspects that we presented may be useful within your specific organizations?
Well, I will say this. Now, as Northkey is part of the CCBHC demonstration in Kentucky, we will be reporting on preventive care and screening for tobacco use, and the performance measures includes eligible consumer encounter CPT codes, and I'm looking at them, and during the presentation, I was like, okay, yep, that's one I see here for us, like. And because I am no expert in CPT codes or anything like that at all. So, but I will be kind of looking at what the presentation again and the notes from it, and just kind of comparing it to what I'm seeing that the state is telling us that, you know, that of our eligible codes that we can use, and just kind of reviewing the presentation alongside this.
That's excellent. Thank you, Christine, for sharing that. And again, another thing is your organizations do have coding people. And I think when they become aware of these codes, I don't know, but they may be able to help the healthcare providers navigate when to use them, and especially the documentation, especially if you're receiving Medicaid or some other managed care organizations. They do like to see documentations in specific ways. So embedding these codes into the practice then becomes, you know, something that you go a little bit back and forth, but then you get it in process. And then it's reimbursable. I think what I see is that many organizations do not use the codes.
Yeah, and I recall when we first began putting the tobacco screening questions and the intervention items in our visits, that our billing specialist was a part of that discussion, and talking with our primary care providers about when to and how to indicate, or, you know, the length of the intervention and that kind of thing, and all that. And again, I'm not an expert in all that to speak eloquently about it, but yeah, she was definitely involved in that discussion. And now we have it though in our therapist visits, and we're getting ever so closer to getting that one pager for them on actually what it means to do an intervention and everything. So.
Well, let us know if you need any help with that one pager, Christy.
We will. Taylor's working on it. Thank you.
Well, thank you all so much for being here today. If we don't have any more questions, we can close. I did drop a link in the chat for you all to provide your feedback on this seminar. We really appreciate it. It's really short, just a few questions, but it helps us know how we're doing and what we can improve on. We will come together again one more time for the last seminar in our series, and that'll be on June 15th. And we'll get to hear from Dr. Akoli. And so he will talk about a multi-team tobacco treatment approach, interdisciplinary teamwork. So that should be a great final seminar for us to conclude on. And we just really appreciate your all's presence today. And thank you for being here. And thank you to Bassema for a wonderful presentation. Hope you guys have a good afternoon.
Thank you.